Thank you everyone for joining us for a webinar on a topic that its importance cannot be overstated, physiotherapy in oncology, and where and what we can contribute along the patient journey. Tonight we'll be presenting the position statement on physiotherapy for people with cancer, which was prepared by the working groups of the European region of World Physiotherapy. Our speakers tonight are Dr. Nele Adriaenssens, who is a professor of rehabilitation and physiotherapy from the Free University of Brussels, Dr. Grainne Sheill, who is a clinical specialist physiotherapist in cancer rehabilitation from St. James's Hospital in Dublin. Both will present the position statement. We have Claire, who is a patient, and will share her story with us. Dr. Carmen Suárez from Seville University, who is the first vice chairwoman of ERW Physiotherapy, who headed the development of the position statement, will summarize everything and where we're at, and I'll present the infographic. Following the presentations, we'll have time for questions and answers. It's important that you know that the session is recorded. You can post your questions in the Q&A section in the bottom of your screen, and you are more than welcome to chat along and tell us where you're from and whatever comments you've got. And we'll start the evening with a recorded opening remarks from the chairwoman of the European region of World Physiotherapy, Esther-Mary Darcy. Lydia, can you please? Thank you.
Welcome everyone to this, the 5th webinar in the series of the Europe region webinars. I am Esther-Mary Darcy and I am the chair of the Europe region, and I am delighted to be coming to you to open this webinar. This one on cancer is based on the work of our cancer working group and has been one of the 2 main clinical themes on which the European region worked on in this last term, and indeed this is the last webinar of the term. One of the reasons that we chose cancer was that while the role of physiotherapy is well known among physiotherapists, it may not be known as well among the public, and our aim with the working group was to enhance the profile of the role of physiotherapies in cancer care in Europe. And this evening, I'm delighted that we have a panel to speak to you on aspects of the role of cancer from a physiotherapy perspective, and to really, I suppose, launch in a pre-launch way the paper that this working group has put together on the role of physiotherapy in cancer. And I'm very proud of the work that they have done. I think that this is a great document, and I hope that many people will benefit. If we increase the knowledge of our role, then we increase the impact of what we can do, and this is to the real benefit of the citizens of Europe, and ties in very much with the EU Beating Cancer Plan. So thank you for inviting me to open it, and I'm looking forward, as I'm sure all of you are, to the webinar. Thank you.
Thank you to Esther-Mary. And now we'll start with the presentation of the position statement. Nele, you can share your presentation by Nele Adriaenssens, who is part of the group.
Thank you, Nirit. Thank you, Nirit, for the introduction. Can you see the slides?
Yeah, perfect.
Okay, there was already an introduction by Esther-Mary, as you have seen. And so as Nirit explained, and as Esther-Mary also explained, we made a position paper based on some statements that we thought were very important as a physical therapist and to describe the role of physical therapy in cancer care in the European region. First of all, what I think is very important and why we chose this thematic work group is because in the last decades, there was a big switch from patients who survived and who had the diagnosis of cancer. They were advised to have a lot of rest and to have a lot of recovery before they went into their activities in daily living again. And so that's a big change now. Now, literally, the patients are fighting their cancer, and we as a physical therapist have an important role in supporting the patient in fighting this cancer, because it's not only advising the patient and promoting physical activity and giving exercise, making exercise programs, but it's much more than that. It's also the behavioral change toward a more active lifestyle, for example, that we have to do as a physical therapist. Because now, and I will go to the next slide, we have divided the position paper and we named it the cancer patient's journey, and we have divided it over different time periods that the patient goes through during this journey. And I will present or focus on the first parts in this journey. So pre-diagnosis, actually how we can prevent or help prevent as a primary prevention the existence or the onset of cancer, but also when the patient has this diagnosis, what we can do as a physical therapist, what our role is before. This is a closed window, not a big window, but also during the treatment. And later on, my colleague, Dr. Sheill, she will discuss more in detail the rehabilitation part and further on the survivorship phase, but also the palliative care phase. And so, as you can see here, there is a lot of evidence on how we can help preventing cancer. At the left side of the slide, you can see that acute exercise, so you don't even have to be an athlete, with acute exercise, there are a lot of physical effects and endocrine effects that in the end will prevent the tumor from growing and from developing metastasis. So with the physical activity, we can prevent this even with acute bouts of exercise. And when you have chronic exercise, this will also have an impact on the growth or the development of neoplasms. And so we can prevent this. You can see that it has an impact on the immune system. And as you all know, the immune system is very important also to attack inflammation in cancer. And then at the right side, as I already discussed, during these different phases of the cancer patient journey, you see that in every phase we can have an important impact. And of course, the most well-known what we can do as a physical therapist, our role is supporting the patient for physical activity and giving exercise programs. And what you can see in the detection phase, so before the diagnosis in primary prevention, you see there is a lot of evidence that we have an impact with exercise on the growth and the development of a possible tumor. On the other hand, during the treatment, during anti-cancer therapy, you see that with exercise, we can help the patient to enhance the drug tolerance, we can promote the efficacy of the treatment, and we can also ameliorate the adverse effects of the treatment. So those are, I think, very important things that we can help the patient to manage the symptoms and to prevent the cancer from getting worse or from the onset. And later on, as I said, my colleague will explain the other parts on the survivorship and unfortunately sometimes the palliative phase. This is, I think, the biggest evidence that is existing on what we see, what we do with patients, physical activity before the diagnosis. It has a preventive effect in 7 or 8 kind of tumors, that we have the proof that there is a positive effect, that people who do physical activity will have less chance to develop a cancer and to die from a cancer, so a cancer-specific mortality, but also the all-cause mortality. And the same thing we see after diagnosis, the patients that are physically active, that are doing exercise, their survival chances, but also the chances for a cancer recurrence, they are much, much better than patients who are not physically active. And we as a physical therapist, we have a very important role in this phase for the patients to promote this, to advise this active lifestyle, certainly when you can convince them with these very important results. So actually what you can see when a patient goes through cancer treatment, actually the impact, the influence on the human body, it's kind of similar to what you see when an astronaut is making a space flight. And so, as you know, you have seen it, it's very actual, I think. An astronaut, he has to prepare to go to the moon. They have to do very strict and very intense exercise programs because their body needs to be prepared for such a space flight. And that's also what we have to do with our patients. The moment that there is a diagnosis, we already have to start preparing the body for these impacts on the human body, because you will see that the effects that are seen from a space flight and from a cancer diagnosis, they are similar. There are cognitive impairments, immune dysfunction, cardiac atrophy, anemia, gastrointestinal events, but also intolerance for exercise, muscle atrophy, and bone demineralization. So those are important effects that we have to try to tackle from the moment we know that there is a diagnosis, because we know this is coming up. And so as a physical therapist, we are working a lot with muscles, with physical activity, but also with the body composition. And as you will know, there is an important link with the nutritional part. We need each other, the dietitians, the clinical nutritionists, we need to work together in this. It's not only the role of the physical therapist, he's part, or we are part of an interprofessional team. So what you can see during a treatment, the cancer therapy, but also the tumor, they are making the patients very tired. There is a lot of cancer-related fatigue, which is the #1 in complaints of the patients, even when they start at the treatment, sometimes even at diagnosis. And so you see that it is a vicious circle from fatigue to diminishing or decreased physical activity and mobility, leading to anabolism, catabolism of the muscles. The anabolism is decreased, so there is a decrease of the muscle mass and the quality of the muscles. On the other hand, it's not only the muscles that are affected, but also the fat metabolism will be affected. And so we see a lot of patients who are cachectic, and this is also one of the important reasons why we have to start early as possible with interventions for physical therapy, for physical activity exercise programs. And as you can see in the slide, but this is not the topic of today, there is a big interference with the nutrition of the patient, because of course we need nutrients, we need proteins to build these muscles so we can do our exercise programs. This is also something that is important during the treatment and where we can interfere with the treatment of the patient. That is, and it's not a well-known and part of scientific research. There needs to be a lot of research done in this field, but I wanted to share it already with you. When we do exercise, we know that there is an important impact on the pharmacokinetics of drug therapy. So we know that the absorption, distribution, the metabolism and the excretion of chemotherapy, for example, that they will be influenced when you give your patient exercise. A patient during exercise, during chemotherapy, together with exercise, we can have an impact on the effectiveness and on the excretion and the metabolism of chemotherapy, which I think is also very important, that we have an impact in this period of the patient's life. And the last thing that I wanted to share with you is that depending on the complexity of the pathology, but also the treatment of the patient, there are different locations where we can organize this rehabilitation, these exercises for the patient. As you can see in this schedule, there is an analysis of what we have to do, who has to do it, and where we have to do it. And so one of the positions, one of the statements in this position paper, it is that there should be rehabilitation services everywhere available for all patients who had a diagnosis of cancer or who are living with cancer. And it can be in different degrees, but it should be available, and it should be from the beginning, from the start, actually from diagnosis, that patients have an assessment and that they are frequently in a follow-up curve, and that the physical therapists are the main player actually within this field of follow-up of the patient for lifestyle coaching, for example, and exercise therapy. So this field of exercise oncology is very important, and so many of the statements from our position paper are also focused and based on this part. This is for what is the early stage, so the prevention and during the treatment, but my colleague Grainne, she will give you more information on the role of the physical therapist in cancer care during the rehabilitation, so after the cancer treatment, and also in survivorship and in the palliative phase. So I will stop sharing my slides. And then I think we can go to the next speaker.
Thank you. So, Grainne, do you want to share your presentation?
Yeah, thank you.
Good.
Everyone, I was introduced already. My name is Grainne. I'm a physiotherapist working in Dublin, in Ireland, and I'm in a clinical position now to try and implement some of the research in this area into practice, and really delighted to talk today on that post-treatment phase. So once patients go through possibly their prehabilitation and their cancer treatment, then what happens? And this is really important. Europe-wide, we know now that we have 21 million cancer survivors, and that number is continuously increasing, because we're getting better at detecting cancer. So we're finding cancer earlier. So we know about it earlier, and then we can intervene earlier. And we also have better treatments. So the treatments that people are getting now mean that many of them survive cancer treatment and then go on into this more survivorship phase. And we also have better supportive care. So the interventions that we have to increase their physical activity, as Nele has described, are now improving outcomes across the board for patients. And really importantly, we also have 300,000 childhood cancer survivors. And that's a group that, again, as physiotherapists, will need our interventions going forward. And that's 300,000 in Europe. And again, that number will increase over the next 20 to 30 years. So at this phase, the person has finished their treatment, and really the side effects that they will experience depend on what kind of treatment they had. So for different cancers, there will be a different first line or go-to treatment that could include their radiation, chemotherapy, surgery. And the side effects that they experience then are very directly related to that treatment that they had. There can be physical changes, psychological changes, and also social changes. And what we're finding out now is that a lot of these will start to resolve as treatment ends in that first phase, that first year, possibly 2 years after treatment, and some of them then linger. So they can linger and persist for years after cancer treatment. And it's what do we do about these side effects at that point? And many of them are amenable to intervention, and that's why we talk about them. So we're now moving towards the impairment driven model of cancer rehabilitation. So the patient goes through their treatment, and then we're looking to pick up some of these impairments. So pain, cancer-related fatigue. Again, physiotherapy would have a role really in helping patients to manage and minimize these. And lymphedema, changes in muscle mass, and so on, they're listed here. So in the acute phase, as I mentioned, they'll present, but then how do we stop these symptoms from persisting into the long and late onset effects? And the model that's frequently referred to, and I'm just using this slide as we kind of are using this as our approach to how we would structure the rehabilitation. So patients would have their pre-rehabilitation, their acute cancer treatments, and then what about those impairments? They need to engage in rehabilitation so that they can get back to general exercise, because as we know, the benefits for this are invaluable. And they talk about this now in the model of prospective surveillance. And all that means is the sooner we see the patient, the better, which is brilliant. It's why patients that engage in prehab or that we see acutely on the wards before discharge, we then know, and there's a point of reference for how that patient has progressed throughout their treatment. So the role of physiotherapy when patients are finished treatment is so broad, and to try and get it into a presentation would be difficult, and it was very difficult to get it into one document, the document that we've now produced. It's broad and it's varied because we have a role with so many different types of cancer and patients who've had so many different types of treatment. It varies from hands-on treatment, so manual work, it also includes education. And it also includes specialist roles. So we know patients may experience lymphedema, and there's a big role there in terms of manual therapy, compression garments, and again, education, reassurance, and guidance. But it also increasingly involves the role of exercise and counseling and guiding patients on the role of that exercise plays in their recovery. And that could be specific exercise for musculoskeletal impairments. For example, with head and neck patients, they may have accessory nerve involvement and have resultant, muscle dysfunction, and that's quite a specific exercise program. But also broadly, as we've already talked about, that general role of activity and exercise for the patient. When we talk about that general role of physical activity and exercise for the patient, we know now that there are clear outcomes or clear guidance on what side effects we can affect and what side effects we're not sure if we can affect for patients after treatment. So because the landscape of activity in cancer has changed so much over the last decade, a group came together in 2009 to look at all of the research that examined the role of exercise in cancer recovery. And they decided that there were 6 outcomes that can strongly be affected by encouraging patients to be active. And those 6 outcomes are on the left here. So they're outcomes where there was really high quality trials, a large number of trials with a large number of patients involved, and that the evidence was really consistent among all the trials that were included. So there was strong evidence that those that engage in physical activity or structured exercise after treatment can have a reduced anxiety and depressive symptoms, less fatigue, which sometimes is counterintuitive for patients. If they're very tired, they can be unsure of what role being more active will play, improve their quality of life, their physical function, and it doesn't have a negative effect on lymphedema. So that's really important that we share that information with patients. There's moderate evidence that we can improve patients' sleep and improve their bone health, specifically for osteoporosis prevention, because we know patients, both men and women, can be on hormone treatment for years after cancer therapy. And that's really important. And insufficient evidence is how they classed this, but really we're talking about emerging evidence. So it didn't have enough to reach the moderate or strong evidence thresholds. But there are studies to show that exercise has promising effects on cardiotoxicities, peripheral neuropathies, cognitive function, falls, nausea, and really important treatment endpoints. So chemotherapy completion rates and dose adjustment rates. So how much chemotherapy do they plan for the patient to have? And how much do they have to adjust that as the patient goes through their chemotherapy regime because the patient feels unwell or the patient feels sick? We know that patients who are more physically active, they have to adjust their chemotherapy less. So we need more studies in this so that we can strongly say that exercise has a role here, but the evidence is emerging that physical activity can help with some of these outcomes. So what are the recommendations that we should be sharing with patients, and what does this position statement look to in terms of advice and guidance? Well, it is those American College of Sports Medicine recommendations. So anybody during, so this is during, but also after treatment, which is usually when there's a window to get patients back in terms of rehabilitation, they should be engaging with aerobic exercise, moderate intensity 3 times a week, and also strengthening exercise as well. So it's important that we share this with patients and that we guide them to engage in this activity. But these guidelines went a step further. They looked at, well, what specific advice can we give people that are experiencing these symptoms? And I would urge every physio that looks after patients with cancer to look at the guidelines, because now we know how to tailor and make our prescriptions very individualized for the patient, depending on what symptoms or impairments they present with. So firstly, anxiety and depressive symptoms. We know patients should do both aerobic and resistance exercise, and the supervision is really important. For patients with cancer-related fatigue in particular, we know that the intensity of the exercise is important. We need to get them to moderate intensity for them to experience the benefits. The lower intensity programs didn't have a strong outcome. So although patients may be active, we need to try and encourage them to increase the intensity of what they're doing to moderate intensity, a little bit hot, a little bit sweaty, a little bit puffed. And the efficacy is independent of supervision. So if someone presents with cancer-related fatigue, the research would indicate that we could give those patients independent programs to work on. And I've just chosen one more outcome just to give an example of how now we're finding out more about how we can tailor exercise to this group is for patients with lymphedema. So as well as some of the interventions I mentioned already, in terms of exercise, we would encourage these patients to do resistance exercise, but the guidance is start low and progress slow in terms of the weights, and they often need supervision to do this. So again, a clear role for where we can provide guidance and support. So as physiotherapists, when we're looking at our role with physical activity and exercise, we should be trying to deliver our services to those most in need. There are a lot of patients with cancer, but who are patients presenting with impairments? Patients who need individualized programs and supervision by someone with an exercise background and knowledge of oncology. And that's how we might move some of this guidance into practice, is to position ourselves as specialists that are trying to treat and look after those patients with the highest level of need. So that's a summary of where we might find our role for patients who have finished treatment for cancer, often with curative intent and with no plan to resume any more treatment. But there's another group, and that's for patients who have an incurable or advanced cancer or stage 4 cancer that may never be cured. And this is a very important group as well, because increasingly as treatments improve, we know that patients may not reach that cured stage, but often can live on treatment for very long periods of time. So where we used to see the 5-year survival rates for some cancers was quite low, actually now the 5-year survival rates are starting to increase, but patients may have to stay on treatment continuously to achieve greater life expectancy. So for patients who have advanced cancer, again, those treatments that they're on for often years at a time will also have side effects. And they're a really important group that we work with. When patients are on these types of treatments, whether it's in the short term or the long term, we know that they will also experience some of the side effects we explained earlier: muscle impairment, fatigue, deconditioning. But to counteract that, physical rehabilitation and activity for patients with incurable or advanced cancer can increase functional capacity and decrease their fatigue and improve quality of life. Where a specialist is indicated here is to consider some of these side effects of treatment. So if someone is on long-term hormone treatment, we'll be very aware of the effect that that will have on their muscle mass, possibly decreases in function, any increased falls risk, decreased independence, the need for aids and appliances, and so on and so forth. Similarly, in terms of bone health, we will be very mindful of the risks associated with activity and be able to weigh them up in terms of the possible benefits for the patient as well. And we'll also consider the patient's pre-diagnosis or pre-treatment activity levels. And we're able to put that into context to create goals and really patient-centered goals to keep patients with advanced cancer as independent for as long as we can. There's one in particular group that often need guidance and supervision in patients that have advanced cancer, and that's those with bone metastases, where the cancer may spread into the skeleton and into the bones. For example, prostate cancer often likes to migrate into the long bones and into the axial skeleton. But even for patients with bone metastases, we know that exercise and activity has a big role to play in terms of strength, walking speed, muscle mass, and supervised programs have high levels of patient tolerance, acceptability, and adherence. And patients don't suffer those possible adverse effects that often there's concern around, such as pathological fracture and skeletal related events. So we don't, I suppose, have high quality trials on efficacy now. They're emerging, but what we can say is patients will benefit from engaging in exercise programs, but they have to be, again, specific and tailored, and that's where physiotherapists have a huge role to play. And we do have recommendations now. And again, these recommendations just came out in the last year. So it's really important that we are aware of those recommendations for activity and that we can take those recommendations and give that information to patients and design programs in line with the recommendations that will then benefit patients as well. And when patients progress, so often patients will progress towards the end of life, and physiotherapy still has an essential role to play there. So if the prognosis for the patient decreases and we think that they're approaching that more end of life phase, these are the 7 kind of roles that were outlined in this paper by Möller in Sweden. What they did was they looked at 10 specialist palliative care physios to see what role are these physios playing for patients in that palliative or end of life phase. And these were what they found, and this is what we've outlined in this paper, that we have a role to play in counteracting a decline in physical function, in informing and guiding and educating the patient, the carer, and also the healthcare professionals, that we can observe and assess that patient and evaluate their function, their mood, and that we can look for signs and symptoms, that we're very good at finding those signs and symptoms of possible decreases in function or indications for interventions such as pain or discomfort. We can listen, talk to the patients. We're very good at encouraging patients to care for their basic needs, and organizing, planning, and coordinating. And that's quite a broad category, but actually that was something that the family and carers really valued, that physiotherapists have that role to play in terms of function and independence, and they can help patients to plan for what's to come ahead for that. So we're trying again to highlight a lot of this work and these findings in the paper that we've produced. Just to summarize, and this is what the paper, I guess, our summary statements from the paper are. When we're looking at physiotherapists, we do see that we have the knowledge and skills and we can apply them in oncology to play a really important role for patients. And rehabilitation services, we want to integrate them. Like I said, that prospective surveillance model would integrate rehabilitation from the beginning of someone's cancer journey. And we get a baseline for the patient's function, and then we monitor and assess and continue to treat that patient throughout their treatment and after their treatment has concluded. And that's really what the approach that this document takes, and that's where we would like to see our role. If it isn't there, we would like to see it evolve there in the years to come. Thank you very much.
Thank you, Grainne. And our next guest and speaker is Claire, who is a patient from Ireland, and she will tell us about her journey and her story as a cancer patient. So Claire, thank you so much for you're willing to share your story with us, and go ahead.
Okay, thank you very much. Hello, everybody. I was just asked to look at how my cancer treatment affected my body and the role I thought cancer rehabilitation has in recovery from the cancer treatment. Just to introduce myself briefly, my name is Claire. I'm 61 years of age. I'm a teacher. I'm a retired lawyer. I'm married. I have 2 grown children who come and visit me from time to time, but I live just with my husband. I was diagnosed with squamous cell cancer of the esophagus in August of last year. And before my diagnosis, I would have been a very active person. I was working full time, walking, swimming, sea swimming, cycling. I'd taken up running my 60th birthday. So my life changed very suddenly with this diagnosis. And my treatment was divided up into, I suppose, 3 different departments, if you like. First of all, I had 23 sessions of radiotherapy with 5 cycles of chemotherapy over 4.5 weeks. After about 2 months, I had an esophagectomy, major surgery, which was in January. And in between, after the therapy, I had a course of physiotherapy. And after my major surgery, I have, and I'm still ongoing, a second course of physiotherapy. Just to mention the side effects of the radiotherapy and chemotherapy, this would have been in October, November of last year. I think I came through pretty well, but I did have side effects which were mainly, as your speakers mentioned earlier, to do with tiredness, fatigue, nausea from the chemotherapy and the radiotherapy, pain, and because of my specific cancer, difficulties with eating. So the consequences of these side effects meant that I became much less physically active over the period, much less so than prior to the treatment. So although I was advised to stay up, not to go to bed, so I was up, but leading a much more sedentary life at that stage. And as a result of that, I found and noticed, as your speakers have pointed out, that my function, my movement, everything degraded somewhat over that short period of time. So much so that from being somebody who could move very well, I became somebody who could not move that much at all. So after the 5.5 weeks of treatment, I had a rest period. And then I was invited to participate in the first course of physiotherapy with St. James's Hospital in Dublin. And these were online classes, as we had COVID at the time. And in addition, because they stretched over the Christmas period, I was lucky enough to be offered a video of one of the team physiotherapists running through the exercise program. And I can't stress or praise or thank the team high enough, really, because it really was fantastic. It was just brilliant. I would say it was crucial in my own recovery after the treatments, and just extraordinarily helpful and positive in so many different ways. And just to mention a couple of them, I was aware that the program was, as mentioned earlier, it was designed and tailored to my specific needs. And it was designed to increase my own function and movement, which it did. The exercises were all very balanced and focused. and rigorous, and perhaps more rigorous than I would have thought I had been able for at the time. So it was pitched at a perfect level for participation and requiring the concentrated effort on my own part. And of course, as mentioned again, I was aware of the encouragement and support and motivation from my physiotherapy team, which was huge in my recovery at the time. So it was also very helpful to know that this program was professionally designed by professional physiotherapists with precise needs in mind and focusing directly on those precise needs. As a result, I knew and felt myself that I was becoming physically stronger, and this was also very helpful, positive. Also, I was waiting in a waiting period between my therapy and my surgery, and I knew that this was something I could do to help myself, and anybody who has a diagnosis will want to do something to help themselves, and this was really important at the time. And between the end of my therapy and my surgery, with the help of the physiotherapy course and my own exercise, I was able to increase my physical peak function up to 2 minutes, which was huge, I think, for my own morale, apart from anything else. And of course, in the hope, I suppose, the hope is that one can achieve better outcomes with better physical activity. But apart from all that, it was really only after my surgery that I realized just how important this course of interim physiotherapy had been, because after my surgery,
We've just lost sound just for a second.
Yeah.
We unmute you.
am I back?
You're back.
Yeah, you're
Okay.
back.
I may have hit something there. I couldn't move at all, my upper body. Just if you think of the slightest movement, I really couldn't do it. But what I did discover was that because I had really been put through the mill with lunges and band exercise, strengthening exercise, all sorts of leg strengthening exercises, that I found new ways of moving that I hadn't ever thought of before, using my legs rather than my arms or my upper body. So that was really huge for me at the time, because it meant that it gave me a certain amount of independence very soon after my surgery, and especially then when I was discharged and went home. I put this mobility, strength and independence down to this actual course of physiotherapy, and for me at the time, it really was life-saving. I can't stress how important it was for me to have had the opportunity to have those physiotherapy exercises and the support of the team behind them. And then just after my surgery, then there was another course of physiotherapy because I had to learn how to use that upper part of my body. So I could not move my head, my neck, my shoulders, my arms. I couldn't lift anything. I couldn't mash a banana, couldn't clear out the grate. I mean, simple functions were just off the cards for me. So it was a question of learning all that movement again, but learning it without fear. And that really was where I think the current course that I'm doing with Dr. Sheill and her team has really helped, because I wouldn't have known how far to go, what to do, because there is much pain involved. So it's really, really helpful again to know that the exercises are professionally designed again to patient need, and that I don't have to fear that I do the wrong thing or too much or anything like that. So it's just brilliant. So I'm recovering, and the classes have a lovely have a go attitude at your own pace, and yeah, I just can't say strongly enough how beneficial it has been to have contact with the physiotherapy team in the hospital, because you're discharged and you're not seen by anybody for a long time. So your physiotherapy team and your physiotherapist is the person with whom you have contact with. And that really is terribly important, I thought, for me personally, to have that contact with somebody still in that context.
That's brilliant. Thanks so much, Claire.
Okay, so just thank you very much. I just say, yes, I think physiotherapy is just both after surgery and before surgery. In my story, it has been very positive. Thank you.
And that before surgery part you're referring to is the prehabilitation, as we would call it, or as it might be called in the research, that preparation, or kind of after the chemo radiation, getting ready, the preparing for surgery. So we're delighted that you were referred to us that early, because it all relies on a referral, that you were referred over to us for prehab, and that you then join back with the rehab program after your treatment. So thank you so much for sharing kind of your experience. I think it puts things in a different light. We can read all the papers in the world, but when you actually hear how someone found it and how their body was and changed with input, it's invaluable. So thank you so much.
And thank you, Grainne, as well, for getting Claire to join us this evening, and for all the excellent work you're doing.
They're kindly offered when suggested. So yeah. Thank you, Claire.
Thank you, Claire, so much. The next speaker is me. I'll present the infographic that we've made with to go along with the position statement. And we wanted to have both the visual and some of the information from the document. And so we included the patient journey and the different stops, and then the major statements in each stop or in each phase of the patient journey. And the first one is prevention. And there is evidence that exercise is important for cancer prevention, specifically lowers risk of 7 common types of cancer. Usually we get the patients when they're patients already. But we get a lot of patients which are non-cancer patients. And it's a good idea to tell them that by doing physical activity, they can really lower the risk of getting sickness cancer. So that's a prevention, and we just mentioned it in the document. The next stage, which Ronnie just talked about, is prehabilitation. And that's before the patient gets to have his treatment or his surgery. And we can provide exercise-based prehabilitation to patients with the goal of enhancing functional and physiological capacity. It's challenging to get the patients before the treatment, but still when there is a chance, we should aim for it and try to get them even a few weeks of prehabilitation before they start whatever they are doing next. The next stage is while the patient get the cancer treatment. We can manage and improve specific side effects of certain impairments, such as, probably the most important is fatigue, which is the most prevalent of all symptoms, and the one which most patients say is the most disturbing. And exercise can lower fatigue quite dramatically. And we can prescribe and adapt exercise programs according to the patient's ability, capacity, and symptoms. The next stage, which is probably the major one, the main one, is rehabilitation following treatment, or during treatment, following surgery. And then probably the most important statement of the document is that patients should be offered access to cancer rehabilitation. It's obvious in some places, some countries, and in some others, it's just not an option, and they should be offered to get rehabilitation. Physiotherapy-led intervention, including exercise, are known to improve cancer-related side effects. Again, fatigue is dramatically affected by exercise, and then functional ability, functional capacity. by the end of whatever treatment those patients get, they are really, really deconditioned, most of them. And we need to get them to rehab for an exercise program, for whatever they need, and tailor to their own wishes and goals. After cancer, monitoring and treatment of long-term side effects such as lymphedema, symptoms control and optimization of function, and with advanced cancer patients, it includes symptoms control, optimization of functional mobility and education, and that includes palliative care. Getting patients to keep their mobility is important, and even when it's really limited, just a few steps usually is it means a lot to them at that stage. So that's our infographic with the main statements of the document about the role of physiotherapy in cancer. And remember, physiotherapy, as physiotherapists, we're experts in human performance. And now I will pass it on to Carmen, Dr. Carmen Suárez, and she will summarize the document and the webinar, and then we'll have some time for questions and answers. Carmen, it's all yours.
Thank you, Nirit. Can you see the screen, Nirit? Perfect. Good evening to all of you. First of all, I would like to thank the participation of Claire, who has accompanied us. Thank you for sharing your valuable experience with us this evening. I would also like to thank the more than 250 attendees to this webinar, which I hope is of interest of you. And finally, to the speaker physiotherapist, Nele Adriaenssens and Grainne Sheill, thank you for the clear presentation in relation to the work developed by them and all the members of the cross-thematic working group of the Europe region of Role of Physiotherapy. This document is entitled The Role of Physiotherapy in Cancer Care during the period 2020-2022. As it has been mentioned, this working group is focused in cancer, health problem that seems that in the next 15 years, it will become the main cause of death. A disease whose number of diagnosis cases is increasing and where the number of survivors is also high due to the early detection, existing treatment, and supportive care. There is a need to develop the care provided to people diagnosed with cancer within Europe and to ensure patients receive the care needed to maximize their quality of life during and after cancer treatment. For this reason, the aim of the document done by the working group theme of this webinar is to outline the role of physiotherapy in the pathway of cancer patients as an effective and cost-effective treatment. Throughout the presentation and the infography, the role of physiotherapy in different cancer-related time periods has been exposed in more detail, including statements about physiotherapy in prevention, rehabilitation, during cancer treatment, post-treatment rehabilitation, long-term rehabilitation, and people who live after cancer and the advanced stage, based on the updated research. But I would like to highlight some general points, some general conclusions from this work and from today's webinar. The role of physiotherapy spans from cancer prevention to palliative and end-of-life care. Physiotherapeutic interventions offer a solution for many of the impairments or symptoms experienced by patients living with and beyond cancer, such as decline in physical function and quality of life. Also, specialized physiotherapeutic interventions can manage complex cancer-related side effects. A key physiotherapeutic intervention for the oncology patient is exercise prescription. Exercise in patients living with and beyond cancer has been shown to be a feasible, safe, acceptable, and effective treatment in every cancer-related period. There is growing evidence for the benefit of exercise on cancer-related health outcomes like improved survival, less fatigue, improved physical functioning, and better quality of life. Physiotherapy should be included as member of the care planning interdisciplinary team from the point of diagnosis and throughout the duration of the cancer care plan to provide evidence-based intervention to patients living with and after cancer. And special relevance need to be taken in the experience and perspective of patients, as Claire has shown us today. Thank you very much for all the participants' attendance and for all the speakers' participation.
So thank you, Carmen. We've had a few answers and Nele is answering them as we go along, because they're very specific. If you have any questions from participants, please post them at the Q&A on the bottom of the screen. And I would like, while this is we're waiting for the questions, I would like to ask the panelists, do you think that to move a bit away from the document to what we're doing with it, do you think cancer rehabilitation for cancer patients is covered well enough in most physiotherapy education programs? And do we need a specific course or unit for this topic, like we have for stroke rehabilitation or for orthopedic rehabilitation? Nele, do you want to try and share your view on that?
Yes, sorry, I was still answering questions in the
so
Q&A.
okay, you do that. And
Okay.
Grainne, what's your opinion about state of education?
Yeah, I think it probably varies a lot, you know. There is a move, I guess, in the last few years, you know, to improve the education that's offered. And certainly I'd like to think that more undergraduate courses are including cancer in their undergraduate education, but I still think that we couldn't say that we do it across the board, that we couldn't say we do it in a lot of countries or most countries. I still think there's a big piece of work to be done around integrating it in as part of the core modules, like every other module we'd have in an undergraduate syllabus. Postgraduate, like there are options to do it, but again, it's quite varied country to country, and some countries are way ahead of other countries. So it's to try and share that knowledge a little bit more, and to have those programs available to physiotherapists regardless of where they are. So I think that's, again, something that we need to do, we need to take on, because the evidence is quite, you know, as we've seen today, is quite strong and convincing. So we need to make sure that we're bringing ourselves and the physiotherapists qualifying behind us up to date.
Thank you. Carmen, you are head of the education working group. Do you have any information of which countries are actually integrated cancer rehabilitation into their education and which are not? And how do you think everyone can use the document next year when they get to university?
We don't have the right numbers needed, but because, as Grainne said before, varies very much between different universities, but it's a tendency to try to include contents about physiotherapy and oncology at an entry level at an entry level. But we don't have the right number or the correct number in relation to how many of them included. But I think it's I think this document is a good tool and a good resource, both for clinical practice and also for education, is to, you know, to promote the benefit of this role of physiotherapy in cancer care. So it's needed, given the evidence, also to include more, much more this content in at an undergraduate level.
Thank you. Thank you. There are many questions about metastasis. So different cancer types, different organs. Can you, Grainne or Nele, can you give us a general direction about how to approach the problem of metastasis, and when the patient can go to rehab or do exercise? Nele, do you want to answer that?
Yeah, I think it's a very important topic because more and more patients are surviving, and so they have these kind of problems that we didn't experience a few decades ago. So they need these treatments as well. And there is an important review that has shown that when the metastasis, and then we're talking about bone metastasis in general, a systematic review of Weller of 2021, and it's about oncology, but hematology as well, and that we always should encourage the people with metastasis to be and to stay physically active. But there are, of course, a few cautions that needs to be taken. But when the metastasis, the bone metastasis of the vertebrae before, by example, if they are stable and they are treated, there are always, of course, adapted exercise programs that can be followed without taking too much risk. And the risk of not being physically active has much more risks for your health than being active with bone metastasis. And I think this is a very good systematic review, which has also a few recommendations for clinical practice, that as a physical therapist, we need to have a minimal background information on, are they stable, those metastases? What is the location and the kind? Because there are differences between when where it lays in the bone, if it's in osteoblastic or osteolytic, for example, metastasis. So those information, are there any neurological symptoms, osteoporosis, pain, are there any fractures before? Is there a risk of falling, for example? Those are all things that we need, information that we need to gather from the oncologist or the hematologist, and then we can make a perfect risk-benefit assessment. And as I said, and which is the information from the systematic review, which is from 1 year ago, so very recently, is that it's always better to stay physically active for your health, even with bone metastasis, than being sedentary.
Thank you. There is a question or a request about referral pathways, how to get the patient referred to us. I'd like to share our experience while I work in the Tel Aviv Medical Center. It's really, really hard to get those referrals, especially when you just get the program going. And we got from few not oncologists actually, family physicians. We had a lot of the alternative treatment people. I heard about rehab and sent them to us, which was surprising. And then once we got it going, it was mostly the patient networks, including in social media, which got the patients to ask for a referral. So I think I recommend that you get in touch with as many patient groups as you can and try to get the information to them and then they will request whatever fits their time and the needs. And does anyone else has any tips about referrals? Grainne, you
Yeah, I think I've spent the last few months working on this, and it's a big awareness, kind of a project to do for awareness as well. Like, talked about it already amongst physios, but that's broader. When we look at other healthcare professionals, we need to, I guess, highlight our role and what we bring, what we can offer these patients, and then reach out to people and start to make those partnerships. So it's work, but the advocacy that we can do is great, and the advocacy our patients, can do as well. Patients going back to the team and saying, I found this really helpful. That's brilliant. The team will then get used to sending referrals and be encouraged to send referrals. So I think that's really important. A lot of my referrals would come from the nurses in the teams as well. So I think it's really important to reach out to them and be very clear with your referral criteria, who should be referred, because sometimes there just isn't that understanding of, who's indicated, what you offer. And then a kind of a pathway for referral to make it easier, because the nurses are in very busy clinics. That's the environment I'm in. And I'm looking for them to refer over. But yeah, it's a big piece on kind of awareness and advocating for, for the role with our patients.
there is a question about the guidelines for specific exercises for different cancers, and I recommend the ACSM roundtable recommendations actually addresses it, and it's open. They've got a very practical infographic. So
Yeah.
it's the ACSM roundtable recommendations where you can get.
And I think it's really important to think about it in terms of impairments or side effects, that there mightn't be specific, guidance for different cancer types, because we're looking again at what treatments the patient had and what are their side effects. So that document is done again by side effects or by treatment, and that might be a useful way to look at it.
Liva, are there any other questions we didn't answer yet?
Nirit, I just wanted to add something for the guidelines, because in the 1st of March, and it's a pity that it's only in Dutch. So for the people of the Netherlands and Belgium, it might be an added value, but they will translate it. The KNGF guidelines, I think they are well known because they are always translated in English. And so they will do it, I suppose. But they also have a very important document that they published very recently. And it's also with recommendations for physical therapists. And it's based on also specific symptoms that we have to take into account. Like, for example, bone metastasis is one of the items that is explained very well in the document, but also cardiotoxicity and polyneuropathy, etc. So let's hope that it will be translated soon. But for now, the Dutch-speaking people and colleagues, they can also use it maybe.
I think they actually let us know that they're going to translate it to
Yes.
English, and to English. Usually they do it really quickly, so we're all looking for it. Yeah, waiting. Thanks. There was a question about are there any particular outcome measures you would recommend for rehab in childhood cancers? And I would maybe open it up a bit. Are there specific cancer related measures you recommend, or the document recommends, or is it just, again, as you keep pointing out, it depends on the symptoms and on patient characteristics? What would you recommend?
I've just posted a link to 2 papers, and one of those is on assessment. So I hope that's helpful.
Okay. So I think we're done. We don't have any more. Yeah, there is Nele, someone is requesting if you can put up the reference. And yeah, I think again, apparently the issue of metastasis is really on people's mind. So I think we already answered that.
I've done a presentation with a colleague for our hospice and palliative care institute here in Ireland, and that was recorded. So I've just put the link to the YouTube video in the chat. So if anybody feels like listening to another presentation or wants to save that link for future, that presentation is on physical activity and bone mets. If it's helpful to people, it's there.
Thank you. So I think, Carmen, we are ready to finish this up, right? Yeah, I think this evening we had many participants. We had at one time over 260, and I think we are covering a topic which is so important. There are so many patients out there with just waiting for us to be able to give them access to good rehabilitation services, because the impact on the life and of the quality of life and the life and the survivorship is so big. And so I think it's we should do everything we can to advance those services and to advance this care. And I think the document will be one important step forward. So thank you to all the panelists and to all the people who took part in writing the document, and to Claire, who shared with us insight. And good night to everyone. Thank you.